So, well, everyone, thank you so much for having me. And I really thank the committee and the organizers for inviting me to talk. Um, Today, we're going to talk about Moyamoya disease and some cerebral revascularization strategies. I'm at the Cleveland Clinic, and we get a fairly large referral for Moyamoya. So we see a large volume of this, do a lot of surgery for people with Moyamoya having hemorrhagic and ischemic strokes from this. Before we start, just wanted to show a little bit of where I'm speaking from. So I'm calling from Cleveland, Ohio. We're sitting right on Lake Erie here. So this time of the year it gets pretty darn cold, but this is a picture of northern Ohio in Cleveland, and the Cleveland Clinic has a very large network of hospitals around northern Ohio. So you can see most of these hospitals here. We're sitting here at the Cleveland Clinic where that blue star is. And there's many hospitals that refer us patients. Our catchment area is about 5 million people that we serve in northern Ohio. We also have a lot of international locations in Canada, Nevada, Florida, international Abu Dhabi, and Cleveland Clinic London is opening up soon. So we'll be seeing more patients from that. So this is the Cleveland Clinic. For those of you that have not seen it, it's a beautiful place. Please come in the summertime if you're going to come visit. I'll show you some pictures in a second in the winter. It's not as nice, but that's the Heart and Vascular Institute right here, where we do a lot of our operations. This is the new medical school that was just built, housing all the medical, dental, and nursing schools. You can see Lake Erie in the distance here. There's Lake Erie. This is where our football team plays, and you can see the beautiful lake that surrounds the city. So great place to live. Very happy here. These are pictures of some of my kids and their friends having a nice day on the lake and sailing. So this is what Cleveland really looks like, though. So this is Cleveland in the wintertime. So again, like I said, please join us in the summertime if you're going to come for sure. And here are my kids. We have fun anyway. We play in the snow and we have a good time, but much better to come in the summertime. So let's get down to business. Some objectives here. We're going to review Moyamoya. I think you probably already heard a talk, it seems, about some vasculitis in Moyamoya. So won't spend too much time on that. I really wanted to dive in a little bit on some of the collateral patterns that we see with Moyamoya. Some of the typical collateral patterns, some dangerous collateral patterns that we've identified here and that others have identified. We'll review some surgical techniques and how do we here in Cleveland Clinic treat Moyamoya disease. And then I did want to talk a lot about some of the innovations in bypass surgery that we're working on. I think the field today is really based on endovascular, and a lot of the endovascular techniques get a lot of the credit for innovation, but we still are trying to innovate in the surgical realm as well. So we'll talk a little bit about that. So again, going into the definition, I think everybody in the audience probably knows this, that it's a rare progressive disorder. And when we talk about Moyamoya, I think when I think about it, really it's the classic Moyamoya is both carotid arteries are blocked at the skull base. And you tend to see this typical collateral pattern like you see in the picture to your right, this puff of smoke. And we'll talk a little bit more about these collateral patterns in a bit, but that to me is Moyamoya disease, bilateral carotid artery occlusion and these potential collaterals. The pathology is hard to come by. A lot of it is unfortunately from autopsy studies and things, because it's very hard to, take a bite out of the carotid and send that off to pathology, obviously. But I think a couple of things that we see is we do see fibrocellular thickening of the intima. You see this sort of classical waving of the elastic lamina and a thinning of the media of the arteries. I think this sort of does show that there is some type of an inflammation going on here in the intima. And there is some work going on now with circular RNA and neutrophils and some of the inflammation into the artery from this. But this is the pathology that typically is seen. So for etiology, I don't want to spend too much time on this. I've put in bold a lot of the things that we see here in Cleveland, but there's hereditary and genetic is about 10% of patients, and that seems to be more of an autosomal dominant with incomplete penetrance. We are questioning whether it is immunologic. We do see a lot of our patients that have a high incidence of circulating thyroid antibodies, such as Graves' disease and thyrotoxicosis. Is that a syndrome of Graves' disease, or is it truly Moyamoya? It's hard to know. A couple of these things I've listed down here: ACTA2 gene deficiency, we see occasionally here, usually presenting in the pediatric population. I operate on a lot of Down syndrome, whether it's children or Down syndrome patients in their 30s and 40s. And we see a lot of these patients with Moyamoya. I think an important one to remember is NF1, a patient that shows up with any type of a lesion in the brain, like a tumor of some sort, and Moyamoya, I think is NF1 by definition. We do see some sickle cell, and I think FMD is also an important thing to think about when you're thinking about what's causing Moyamoya. But that's for classic Moyamoya. And I put this next thing up, this Moyamoya syndrome. And I think that this is interesting. I think a lot of the things that we see may not potentially be Moyamoya disease. It may be something else. We see a lot of patients where it's just unilateral carotid occlusion or unilateral MCA stenosis with some collaterals or unilateral MCA occlusion. Is that truly Moyamoya disease, or is it one of these other diseases that sort of mimicking Moyamoya disease? So I think this disease, because we don't have just one single marker to say this is Moyamoya, it gets kind of classified as the syndrome. It can make following outcomes and treatment a little bit challenging because we don't know if we're treating classic Moyamoya disease. So always remember that Moyamoya syndrome exists, and we tend to use that when we don't really know, is it truly Moyamoya or not. As far as the epidemiology goes, I think most people know this. Much higher incidence in Japan, in China, here in the United States. Number of cases that was reported in this is a yearly reported cases, 154. We think there is a little bit more female predilection. Certainly here in the United States, we do treat many more females. I would say this stat holds true, probably about double. Classically, we do see this two peaks of age distribution. Our classic patient is sort of 8 to 10 years old, but then we have a large, peak around the 30 to 50-year-old age. And family history, I think, does play a little bit of a role, not so much here in the United States. So we're going to be talking about some bypass, and I do like the history of surgery, and especially the history of neurosurgery. And Yashar Gill really needs most of the credit for sort of pioneering a lot of these bypass techniques. When he moved to Vermont, he joined Donaghy's lab. Donaghy's lab at that point was really focused heavily on microsurgery. But even when Yashar Gill arrived, Donaghy was already achieving about a 66% patency rate in experimental microvascular anastomoses. But when Yashar Gill came, that's when really things started to pick up. He was the first one to do an STA to MCA bypass in a dog. And then he performed the first external carotid and internal carotid artery bypass for carotid occlusion in 1967. I can imagine the instruments and the microscope, if they even had one at that point, or magnifier that they were using. And then in 1972, Yashar Gill performed the first STA MCA bypass in a patient with Moyamoya disease. This is the first reported case of that. So for a clinical presentation, as most people, and as we all know, probably in this audience, stroke is the main thing we worry about. And in our practice, what we typically see are TIA symptoms. They can be sort of a stereotypical repetitive. A lot of times we'll see limb shaking TIAs in patients with Moyamoya disease. Strokes, particularly in the watershed distribution. But remember that watershed in Moyamoya is constantly changing. And so it may not look exactly watershed, but ischemic stroke is definitely something that presents. And intracerebral hemorrhage obviously is a big player here. Patients with intracerebral hemorrhage from Moyamoya disease tend to do much worse, obviously, than ischemic stroke. There's always this talk that overall and in general, ischemia tends to be the predominant presenting symptom in kids and hemorrhage in adults. I'll tell you, in our practice, we largely see ischemia across the board. Hemorrhagic disease we do see, but it's much rare. It's much more rare than the ischemic presentation is. Occasionally, we'll see some sort of stereotypic movement disorders, but these are typically what we're seeing. But I would tell you probably about 90% of people are presenting with ischemia in our practice. So I thought this was an interesting paper, and this is my friend Judy Wang at Johns Hopkins University put this paper together. They looked at the racial phenotypes in Moyamoya disease, and they sort of compared the clinical presentation and natural history. And if you look at the different populations they looked at here, sort of depending on different ethnic and racial populations, you did see, in some, populations, more pediatric disease than adults, but overall, it was sort of consistent, definitely more adult than pediatric disease. I thought this was interesting, though, when you look at the Asian population versus non-Asian. It's much more of a 50-50 split in the Asian population, ischemic and hemorrhagic, versus a non-Asian where it's more ischemic, and that's definitely what we see here, and more in the United States is more of that ischemic disease, like I said. So real quick, I just wanted to talk to you about our imaging evaluation and how we evaluate patients that come here to the Cleveland Clinic. So most of the patients have a plain CT scan, usually part of the initial evaluation, looking for hemorrhage and things of that nature. Obviously important. Everybody has an MRI, and I think a couple of things, and I'll show you a case in a second here about MRI. We're looking for infarcts, but the other thing important to look at, remember, is looking at chronic volume change on the affected side of the brain. You see a lot of patients that may not have acute infarct or chronic infarcts, but they're just losing volume and losing atrophy based on hypoperfusion, and that's something you really want to look for. We always do angiography on patients, really confirming the diagnosis, staging collateral patterns, looking at the superficial temporal artery and potential bypass conduits and things of that nature. We do use perfusion imaging. I think in this population, if patient's symptomatic and has angiographically confirmed Moyamoya disease, I don't know how important perfusion imaging is. We're probably going to treat that patient. But I think it is really helpful in the asymptomatic population. We have a lot of patients that will present, let's say, with headache or something. They get a scan and they find Moyamoya vessels. So it's more of an asymptomatic presentation. And I think MR perfusion is helpful if you see, a large area of hypoperfusion. Maybe you want to think about being a little more aggressive in that patient, especially if they're young. And remember, with perfusion imaging, it's a little bit difficult to interpret with bilateral disease. So I always show this case, and this case, it was a big learning case for me. And it was a case that was referred from another hospital, and they didn't have surgeons doing surgery for Moyamoya disease. It was a 55-year-old that had these sort of presented initially with this acute sort of watershed territory infarction, and you can see the flare imaging here. They had some infarct as well. Angiogram was done, and this patient obviously, I think, was higher on the Suzuki scale that we'll talk about in a little bit, but did not have a lot of the Moyamoya collaterals. Really, carotid was very shut down. Had a nice superficial temporal artery that could have been used for bypass. And from a collateral standpoint, they had sort of your classic, PCA into the, sort of the medial posterior choroidal, lateral posterior choroidal, territory, and maybe a little bit across the ACOM here, and some flash filling, but not much going on here. Very hypoperfused just from an angiographic standpoint. And perfusion imaging, so just what you would think, extreme hypoperfusion, misery perfusion of the right hemisphere. And this was the outcome of the patient. So the patient just had a subtle, gradual decline over years until they were, until basically that right hemisphere sort of had melted away. And this patient did clinically very, very bad. This is when we saw the patient, and at that point it was too late. And so when I saw this, I really sort of, got into my head that, I think Moyamoya, especially in a symptomatic and when they're hypoperfusing, is truly a surgical disease. They need more blood flow. So what are the surgical results? And there's a huge literature on Moyamoya. If you get into the literature and look at this, when I was preparing for this talk, I just wanted to update myself, but I just couldn't believe how many publications there were just in 2019 alone. But a couple of studies sort of stand out. This is Kim's study in neurosurgery 2016. They had 441 patients over 14 years, 301 revascularization procedures versus 140 medical treatment. The follow-up in the surgical arm was 44 months, and then 77 months in the medical arm. In this trial, the number needed to treat to help one patient was 10, which is fairly good. I know we're all used to mechanical thrombectomy now, where it's basically you need treat two patients to help one, but this is fairly good. And in their multivariate analysis, surgery was an independent protective factor against stroke. And if you look at this is the medical arm versus the surgical. Any stroke rate was basically 19.6 throughout their follow-up, and the surgical arm was in the single digits, was 9, and that included ICH. Their ischemic stroke rate much better, obviously because they're decreasing the hypoperfusion, and the relative risk reduction was 52%. So in pediatric Moyamoya disease, this is only 24 patients. There's less of the pediatric patients, but a lot of the patients were treated with indirect bypass, so EDAS or EDAMs, or direct bypass with some indirect. And the clinical and imaging follow-up was 4 months and 5 years. What they found in this study was that indirect bypass, which we'll talk about in a little bit, this EDAMS procedure alone is very effective at achieving angiographic revascularization. 80% of the patients had angiographic relief, meaning that they were getting good blood flow to that hemisphere. The direct bypass with the indirect was more effective at immediate post-op clinical symptom reversal about 100% of the time in this study. And this is a huge trial by Kim's group, 629 children with Moyamoya disease. If you look at how many people had the operation, they actually did almost over 1,200 operations for Moyamoya disease. So a huge experience here. And if you look at this, it's kind of the preoperative adverse event was only about 8%. All right. If you look at what I just showed, as far as sort of the medical history of this, it's up near 20%. So they did fairly well from that standpoint. And when you look at, I think this is really an interesting thing. When you look at their yearly adverse events, so when you look at intracranial hemorrhage, extraaxial hemorrhage is only about 2%. That's probably from surgery. Their intracerebral hemorrhage rate was 0.2%, and status occasional patients got was 0.2%. So very good long-term follow-up, safe procedures, and people prevented infarction with this procedure. And here it is. This is their annual stroke rate in operated hemisphere. So look how low these numbers are. It was as an annual stroke rate after surgery. So very good numbers there. So I think this is very clear. Moyamoya in our practice is a surgical disease, specifically when patients are having symptoms or if they're asymptomatic and hypoperfusing.
Dr. Bain, Dr. Bain,
yes.
you have 1 minute more.
Okay.
Yeah.
I can skip back. I just want to talk about some collateral pathways here. So from the collateral pathways, everyone kind of knows about the circle of Willis and the ACOM and PCOM collaterals coming across. I think the classic Moyamoya collaterals we talk about are sort of these puff of smoke collaterals, the lenticular striates, anterior choroidal, and the posterior choroidal vessels that come up over the top. Leptomeningeal collaterals are important. You'll see there's a lot that they kind of come up over the top. And the external carotid arteries, you remember these transdural collaterals, the middle meningeal arteries, and the ethmoidals. Those are big for surgery. So if you're going to open the dura to do surgery, you have to know if those collaterals are there. So these are the pictures we get. Here are the Moyamoya collaterals, lenticular striate collaterals that we see. Okay. Here are the middle meningeal collaterals coming down. So obviously that you'd want to avoid injuring this middle meningeal during surgery. Here's a Down's syndrome patient that we treat. And you see this classic Moyamoya collaterals that are coming across here from the lenticular striates. And again, you'll see the same thing. There's collaterals here with the ethmoidal and the middle meningeal. So you want to avoid those during surgery. I won't go through Suzuki stage for sake of time. Just real quick to remember about this is these 3 and 4s, where you get a lot of these vessels here. These tend to produce hemorrhage. These other vessels down here, when these collaterals start to go away, that's when the ischemic presentation starts. So remember that. The sort of the middle Suzuki grades is where you get hemorrhage, and then this is where you get ischemic, okay? I wanted to show this case to you guys because one of my tasks here was to talk about collaterals. So how does revascularization change the collaterals? This is a 54-year-old with limb shaking TIAs. Here's her angiogram before. So she has these lenticular striate collaterals that kind of come through to sort of reconstitute the MCA. And she has some leptomeningeal collaterals as well. And same thing here. If you look at that, and she has more leptomeningeal collaterals over the top. And here's her STA. We used a frontal branch and did a bypass. So here's her bypass filling. Here's the bypass filling the MCA. And here is the pre-op and post-op. Important point. Look at how much bigger the STA has come over 6 months compared to pre-op. So this will grow over time. And here's our post-op collaterals. You'll see that there's a little bit less collateral pattern here. And if I put the pre versus the post, if you remember what I showed before, here's the MCA sort of filling through these collaterals. You see an extreme reduction in the amount of these Moyamoya collaterals here because there's more flow through the bypass. So we think that this is protective and that the patient has more blood flow. And also they're reliant less on these fragile vessels so that it will reduce hemorrhagic disease. These are the collateral bypass. They disappear as the bypass picks up over some time. Okay. And again, this you don't need a big graft here, just the STA will work. Okay. So can certain collaterals predict symptoms or stroke? Real quick, thalamic collaterals in the hemorrhagic group here was an independent predictor for having more hemorrhage. So more thalamic collaterals, you'll have more. Choroidal and lenticular striates didn't pan out in this study, more thalamic, okay? And if you have more PCA collaterals and PCA involvement, you tend to hemorrhage more. And then again, like I said, in this group, if you look at it more, the 3s and 4 Suzuki stage had more hemorrhage in this group, okay? And one other thing in the lateral lenticular striates, okay, if you have a lateral lenticular stride collaterals, this study showed that there was a higher rate of intraventricular hemorrhage as opposed to medial and anterior choroidal collaterals. And in our group, we looked at some other high risk factors of collaterals when you form aneurysms on these collaterals. So this is a patient that had an intracerebral hemorrhage. We published this paper. This patient, we found during this collateral, here's the M1 stenosis. Here are the collateral patterns coming off. And here's an aneurysm that ruptured. That's the angiographic look here. And we went in, evacuated that hematoma, and then clipped the aneurysm. Same thing here. So in summary, for collateral, stage 3 and 4 Suzuki stages predict hemorrhage. Less collaterals predict ischemia. Ethic factors are somewhat determine the presentation. The collaterals can change after revascularization, and you always look for high-risk features from aneurysms. Because I don't have much time left, I just want to really quickly talk about the choice of a surgical procedure. We tend to choose STA-MCA direct bypass if it's technically possible. It's difficult to do in young children because of their size, but it brings blood flow right away, and it's better if patients are having active symptoms. Indirect bypass for EDAS, it's a lower surgical time. It's less technically demanding, but at 6 months, you'll get very, very good collateralization over some time. I'll skip this movie. This is how we do our indirect bypass. So we basically do a craniotomy, lay the muscle and arteries down, close the dura over this, and put the bone back. And what you'll see is you get a great revascularization. So you get, this is pre-op, this is post-op, and it looks like a direct bypass was done here. So indirect bypasses achieves good revascularization. We are using a new thing. I don't know if you guys use this, but Flow 800 by Zeiss gives you very good intraoperative color maps. And so this is a patient I did that we bypassed this artery. Here's the time to the fluorescent peak here. After bypass, you see it's a much faster time to peak of the contrast. And we were actually worried about a little bit of a hyperperfusion in this patient, but the patient ended up doing well. So we're working on looking at this intraoperative perfusion. I'll skip this complication case and move on to my summary. So Moyamoya is a surgical disease on presentation in our group. Surgical revascularization is superior to medical therapy. There's many studies that show this. One of the unclear things is whether it is better to do a direct or an indirect bypass. We tend to do both, a direct and an indirect, but I think if patients are having active symptoms, use direct. If they're not, maybe an indirect is a good choice. We need further research to determine the etiology of Moyamoya disease and the angiogenesis. I thank you for your time. Sorry, I went a little bit over.
Thank you, Dr. Mark Bain, for the wonderful talk. We can have one question because we are short of time. So if no questions, then.
Dr. Bain, do you
Yes.
think ECA collaterals are important to call it as Moyamoya? Or do you always see ECA collaterals in your Moyamoya disease patients?
Yeah, that's a very good question. So we see more of the external collaterals in the pediatric population. And I don't know if they're just more angiogenic. I don't see them as much in our adult Moyamoya cohort. So I think it's an important collateral pathway. And I always worry when I do pediatric cases that somehow when I do surgery, I'm going to be interrupting those collateral pathways that are always in place. So we'll actually really carefully try, if they have, let's say, a middle meningeal collateral, we'll try to avoid that, maybe go more frontal to it or posterior to it. So we really try, to avoid injuring that. But I think it's a great question.
Should we close?
Convey my regards.
Should we close now and start the next?
Thanks, Dr. Bain. I'm Dr. Raj Srinivas. I've been communicating with you the last few days. It's very late in Cleveland, and thank you for taking the time out. And please do convey my regards to Blaise Baxter.
Yeah.
Will do. Thank you so much, everyone.
Thank you.
Appreciate the time.
Yeah, thank you very much.
Thank you very
Thanks.
much, Professor Bain.